So we can going to start. Good evening, dear colleagues and friends. It's my pleasure and honor today to have this great meeting with great speakers, with a very pioneer um, experts that are going to tackle this subject that have a lot of like what we say difficulties in management, uh, discrepancies between one and the other ones. So we'll try to find some points that we can agree on in these topics about the keratoconus. In the beginning, I would like just to introduce our experts that they are going to discuss this topic after our colleagues, young ophthalmologist presentation. So first of all, we are trying to do our best in MEOM that we are spreading the information, talking about the subjects that maybe sometimes not taking in consideration in many times, even though also we'd like also to support all those they are willing to attend the conferences and the meeting. And that's why in the MEOM meeting, like webinars, in the end of each webinar, we will select one who attend the meeting from the start to the end. So that's why we announce, and this winner, he will get a free registration and accommodation in the next MEOM, the 8th MEOM conference that will be in Dubai in 30 of October to 1st of November 2026. This is just, and that's why I advise every one of our colleagues that they can take this chance and go ahead from the start for 1 year advance that he is ready and register with secure his spot and secure his seat, and at the same time he is having an accommodation. This one, it will depend on the time that everyone said. Then we will select between those they are at the end, and we will announce it either in the end of this meeting or in the beginning of the next meeting. This is first. Now I will go to our colleagues, my dear friends, Dr. Osama Jlaidi. He is a consultant ophthalmologist at Moorfield Eye Hospital in Dubai, specialized in cornea, cataract, and refractive. He is adjunct, also clinical associate professor of ophthalmology at Mohammed bin Rashid University of Medicine and Health Science in Dubai. He is an experienced consultant ophthalmologist with wide range of experience in cornea, ocular service, and modern cataract and refractive surgery. Had 2 years fellowship training in cornea and refractive surgery at the Cornea Plastic Unit and Eye Bank at Queen Victoria Hospital in UK. Follow at the Royal College of Surgeons, Edinburgh. And my dear Osama friend, we know each other only maybe about 2 days, 3 days. Maybe you can double it by 20 years friendship. And he's a well-known figure, and he will moderate this session because he is specialized in this part. So I'm giving only the names is according to the alphabetical. Dr. Abranama Nayak, she is involved in various academic and surgical training courses in ophthalmology, actively participate in instruction course, debates, and webinars in various states as a multiple publication in Index National Journal. She is a refractive surgeon, and we have a pleasure to be with us during the last MEOM that was held in the last month, October, in Dubai. Welcome, Dr. Barnam. Arteshaz Zulfan is a director of Eye Health Institute, Zulfan Eye Care Center. I hope he joined us already.
Yes, thank you very much for the invitation.
Hi, Dr. Arteshaz. Nice to see you and to meet you
The
again,
same.
even on the Zoom. Eye Laser Center at MC Shangivet, head of Department of the Eye Disease of National Institute of Health of Ministry of Health of the Republic of Armenia. He's a good friend of mine, and we are meeting several times. We are happy, and he is one of the pioneers also in keratoconus, and we will be benefit and get a lot of experience from his expertise.
Thank you.
Dr. Cosimo Mozotta, it's a well-known figure in the world, So anything we will say, it will be very less, but he is an MD, PhD, Associate Professor of Ophthalmology, Departmental Ophthalmology Unit, Osul, Toscana, Southeast Head Science of Cross-Linking Center. He is from Italy. I think, which place, Dr. Cosimo?
From Siena.
Siena. Okay. I think also we'll have welcome Dr. Cosimo. Thank you very much for accepting our invitation. And we hope there will be a lot of discussion with this pioneer. They are here. Dr. Krishna Prasad Kudlum, he is a brother and a friend of mine, and he is already here. I thought he is not joining, but he's
No.
here.
Without joining, my dear brother will not allow me to this thing. I will not get a sleep. I was part of IRSA conference from Dr. Mahipal Sajja. I was part of the dinner meet. I just closed down the dinner meet. I immediately rushed in. I have to be part of this wonderful webinar. I think there will be great discussions. I think we will get a lot of points. I think I just wanted
Good
to
point.
tell again congratulations to Professor Dr. Amri for conducting a wonderful, wonderful conference. The scientific program is amazing, wonderful hospitality. I think one day MEOM conference will definitely overtake American Academy. That is my dream.
Oh, this one a dream, a big dream. But thank you very much for the
Not big
kind
dream,
words.
it will happen. It will happen, inshallah.
Dr. Krishna is a well-known also figure. Well-known, he is a cataract refractive surgeon, and he is doing a lot of work. And he is has an extensive experience in smile refractive and phaco-emulsification surgeon. At Dr. Kudlu has also attended, shared, and presented lecture as a guest speaker at various international and national ophthalmic conference. Thank you, Dr. Krishna, for being with us. And also, we will have next. The last but not the least, my dearest and brothers and friends and colleagues, Dr. and Professor Mohsen Baqali. Dr. Mohsen, he's a professor of ophthalmology, University Hospital Rabat and Marrakesh. He's past president of Moroccan Society of Cataract Surgery and Samir, past general secretary of modern Moroccan Society of Ophthalmology, current president of Network Education and Solitary in Ophthalmology RIZO, current head of Cataract Diploma University UIR Rabat. Dr. Mohsen is a well-known also a refractive
Thank
surgeon,
you.
and he is well-known also worldwide. And I'm happy that we are having all these names today to discuss this topic, keratoconus. We took a lot of time, but it's worth that all the attendees will know the figure they are going to meet and listen to them. I will pass the mic also now to my my dear friends, Dr. Aziz Bashir. He is also the president of MEOM Young Ophthalmology Society. In addition, he is a professor of ophthalmology, vitreoretinal, and vice president of Pakistan Vitreoretinal Society and Young Ophthalmology. Young Ophthalmology of Young Ophthalmology of Pakistan. He is going to introduce our speakers, and they are going to present. And after that, Dr. Osama, he will lead the discussions with our colleagues. Dr. Aziz.
Thank you, Dr. Mohammed. And it's great being here, especially after coming back home from one of the highlights of this year, the MEOM conference that was held a few days back in Dubai. And it was a great meeting. And I would like to congratulate you, especially, and all of us for having a great meeting and looking forward to the next years too, inshallah. So we have four speakers with us from the young ophthalmologist part
They
of
are
the
young by
MEOM
the age,
Academy.
but they are very highly expert in their work.
Of course, all of them are working as consultants in their respective areas, and all of them have shown through the past. The first speaker would be Dr. Rabia Sharif. She is a fellow of cornea and refractive surgery in Al Shifa Trust Eye Hospital, Rawalpindi, Pakistan. Next is Dr. Ashraful Haq. He's the founding president of Bangladesh Young Ophthalmologist, and he's currently working as a consultant in Bangladesh Eye Hospital. A very dynamic surgeon, and I've been following him on his social media and his successes, and I wish him all the successes ahead too. The next is Dr. Karan Bhatia. He's the Vice President of Young Ophthalmology Society of India. Again, a consultant cataract, refractive, and anterior segment surgeon, and he's from Meerut, UP, and a very dynamic guy, and takes active part in the young ophthalmologist activity in India and throughout the region. And our last speaker is Dr. Khuraman Ramzanova. She's a consultant cornea and anterior segment surgeon in National Ophthalmology Center in Baku, Azerbaijan. And I'm looking forward to hear them with great input into the very important topic of keratoconus. Thank you, Dr. Mohammed, for having us, and over to Dr. Sama to take this on further.
I think the first talk will be by Dr. Rabia Sharif. We'll talk about why keratoconus is happening and current insight into the history. Dr. Rabia, all is yours. You can share yours.
Hello, everyone. Can you see my screen?
Yes, we can see, but this need to enlarge it.
Okay, I'm going to take it to the slideshow. Is it fine now?
No, still we can see even the other slides.
This is strange.
Please just press on the slide share where you have, just press it again. It will work.
Okay. Yeah, Sunny.
Dr. Rabia, go to the slideshow. Yeah.
Okay.
You have to share again because now it's not sharing.
Okay. Can you see it now?
Yes, okay. Now make slide share.
Should I start now?
I think maybe it's not going to work. So you can continue like that. That's what we will do. Okay.
Yes,
What do you
yes.
think?
Go on, go on.
Go on, yeah, please.
Okay, so I'm Dr. Rabia and I'm working as Associate Consultant at Al Shifa Trust Eye Hospital in Pakistan. So I'll be discussing why keratoconus happens and what are the current insights into its etiology. So as we know that behind every distorted image that we see, that a patient sees, lies a deeper story within the cornea. The older knowledge of etiology of keratoconus says that it is a progressive but a non-inflammatory ectasia of the cornea, which was characterized by thinning of the corneal stroma due to rubbing, protrusion, and cone-shaped cornea. But recently, we have come to the conclusion that it is a multifactorial etiology, and it basically develops due to the interplay between the genetic predispositions, biomechanical and biochemical abnormalities, mechanical traumas, environmental influences, and systemic associations.
Dr. Rabia, if you don't mind, we need you. You have to click in each slide because you are not in a slideshow, so you have to select one by one. So whenever you are talking, then you click the next.
So on my screen, I can see it as a slide share.
No, anyway, but yeah, just I like this.
Okay.
Yeah. So
Is
whatever
it fine now? Okay.
Yeah.
Is it fine now?
Yes.
So the older mechanical hypothesis used to say that eye rubbing due to any cause like refractive surgeries, dry eye, atopy, and computer or screen vision syndrome, night compressions due to abnormal head postures while sleeping, inflammation resulted in increase in the level of proteinases, resulting in thinning of the cornea, ultimately weakening of the cornea, and focal progression of the corneal distension and thinning, which was called keratoconus. But the latest molecular hypothesis says that due to an unknown collagen change due to genetics and associated general conditions, with or without atopy, eye rubbing, inflammation, and release of proteinases, keratoconus happens. So coming to the genetic factors that play their role are that this disease has a strong familial tendency. About 5 to 27% have affected relatives. Heritability has been shown in the twin studies, and the genes implicated are VSX1, SOD1, COL5A1, ZNF469, and TGFBI. And the associated condition in which these keratoconus is seen is Down syndrome, Leber congenital amaurosis, Ehlers-Danlos, and Marfan syndrome. So in Marfan syndrome, so basically Marfan syndrome perfectly supports the theories of keratoconus that attempt to explain the ectatic process. So basically in both we can see a corneal change in corneal biomechanics. And the patient with Marfan syndrome, even though they have flatter corneal keratometries and regular astigmatism, with constant eye rubbing, they are at increased risk of developing keratoconus and the resulting steepening in the cornea due to constant eye rubbing. The biochemical abnormalities that we see in keratoconus is basically there is an increase in the activity of matrix metalloproteinases, and there is reduced production of tissue inhibitors of the eye, that is metalloproteinases. So due to the imbalance between these two factors, there is an increased matrix degradation, and there is resultant thinning and steepening of the cornea. Balance between these two factors is crucial in the maintenance of a target retina cornea. And also there is an oxidative stress that there is a decrease in superoxide diamidase production. Basically what happens is this enzyme is responsible for the dismutation of superoxide to oxygen, radicals, and hydrogen peroxide. And due to the decreased level of SOD, there is an increase in the level of superoxide, and there is increased production of reactive oxygen species, resulting in the stromal collagen degradation and corneal thinning. So basically in this diagram, we can clearly see that during that in the cornea, in a healthy cornea, there are very few reactive oxygen radicals and apoptotic cells, but in a patient with keratoconus, there are a lot of apoptotic cells and reactive oxygen species that are present. So coming on to the fibril theory, that there is an altered collagen fibril arrangement in the patients of keratoconus. There is reduced interfibrillar cross-linking. There is thinner epithelium with focal breaks, and there is weakening of the stromal biomechanics resulting in the cone formation, as it is shown in the diagram at the bottom. And the mechanical factor which is the strongest modifiable risk factor in the patients of keratoconus. It is more common in patients with atopy and with VKC. The mechanism underlying this phenomena is that the microtrauma result in release of inflammatory mediators, which result in increased keratocyte apoptosis and ultimately weakening of the corneal stroma. The environmental factors like increased exposure to the UV light produces increased oxidative stress, allergic conditions leading to itching and rubbing, also an aggravating factor to development of keratoconus, and rigid contact lens wear, which is a historical association and is now mostly debated. The systemic associations that are seen are atopy in the form of eczema, asthma, and allergic rhinitis. Connective tissue disorders have a strong systemic association due to decreased collagen production throughout the body. Thyroid endocrine functions are also considered important in the pathogenesis of this disease, and sleep apnea is an emerging correlation that is seen recently. So initially or traditionally, it was considered that keratoconus is a non-inflammatory disease. However, the newer studies have shown that elevated inflammatory cytokines in the tears, there is an increased inflammatory cytokine production in the tears of the patients with keratoconus, and there is increased level of IL-6, tumor necrosis factor alpha, and matrix metalloproteinases, especially the MMP9. And eye rubbing is related to inflammation, which may accelerate the corneal weakening by production of these inflammatory mediators. So it suggests that keratoconus may involve a para-inflammatory pathway, as shown by this diagram, that inflammation in keratoconus result in altered extracellular matrix remodeling, and there is increase in the pro-inflammatory factor expression in the corneal epithelium and stroma of the patients. There is increased pro-inflammatory cytokines and this inflammatory proportion in the blood of the patients with keratoconus. Increased risks when associated with immune conditions like allergy and eye rubbing, genetic alteration in inflammatory and immune response, pro-inflammatory factors like a decrease in the pro-inflammatory levels in tear film and corneal cells following collagen crosslink is also seen in the patients after the crosslink is being done. Cessation of the disease progression along with decreased inflammatory mediator following the anti-inflammatory treatment, and the pro-inflammatory factors in tear fluid, corneal tissues, factors associated with disease severity or KC progression. So the next thing that plays a role in the progression of keratoconus is basically hormonal and endocrine influences. It is seen that the patients mostly develop keratoconus and the onset is seen mostly around puberty. And the progression is also reported during pregnancy, and thyroid dysfunction patients are also more prone to develop keratoconus. And these factors help us to make an assumption that the hormones are also pivotal in the progression of keratoconus. Estrogen and progesterone may alter corneal biomechanics, and there is, however, the evidence is still evolving, and the relationship is not fully established. Also, the patients with keratoconus have higher level of estradiol, and even the male patients, they have a higher level of estradiol than the normal population. The patients with keratoconus, they have reduced corneal hysteresis, and there is reduced corneal resistant factor due to their altered collagen fiber linkages. There is abnormal viscoelectric properties. They are prone to deformation. Biomechanical weakening may proceed to visible topographic changes. Also, neurotrophic factors are also seen to play an important role in the progression and presentation of keratoconus. There is a reduced corneal nerve density seen in the patients with keratoconus. This altered sensitivity is due to nerve remodeling. The changes in neurotrophic factors may affect epithelial healing and stromal keratocyte activity, and hence it can contribute to the disease progression. Tear film abnormalities are also seen to play an important role in the progression. There is increased tear oxidative marker production, reduced tear quality in atopic patients. Abnormal tear proteomes are seen in the patients of keratoconus with elevated proteases, and decreased protective enzymes are seen in the tear film of the patients with keratoconus. Also, the tear film dysfunction result in epithelial microtrauma and hence progression. So to conclude, basically keratoconus is not a uni etiology disease. There are a number of factors that come into play, and the etiology involves is basically an interplay of genetic susceptibility, biomechanical imbalance, mechanical trauma like eye rubbing, environmental influences there like UV radiation exposure, and the patient who are using contact lenses and are having some breathing difficulties during sleep like sleep apnea. So understanding the etiology will help in the early diagnosis, risk factor modification, and prevention of the progression of the disease. Thank you.
Thank you very much, Dr. Rabia. That's very cover all aspects. I think we're going to the next speaker. So Dr. Karna Bahati, she will talk about beyond the slit lamp, modern tools for early keratoconus detection.
So thank you to MEOM for this wonderful opportunity. So my topic as given to me is, just a second. Is my screen visible? Can you see my screen?
Yes, yes,
Yeah,
you can.
Yes.
Now?
We can see.
Yes.
So I'll be talking about beyond the slit lamp, modern tools for early keratoconus detection. I'm Dr. Karan Bhatia. I'm a cornea, cataract and refractive surgeon from India, Meerut. I am also the vice president of UC, and I have other collaborations or involvements as well. So traditionally, as the principal had said, that there's a change in the definition of keratoconus, which in the textbooks a little bit later. So the textbooks for the viewers, it's outdated. The latest journals have showed and latest studies have showed that it is an inflammatory disease characterized by thinning of the corneal stroma that may not lead to irregular astigmatism with an associated decrease of visual acuity. Now, coming to the topic. So what are those devices which are beyond the slit lamp for keratoconus? So So mainly these are the corneal topography or the tomography, the anterior segment OCT, and the corneal biomechanics. So let us go to the corneal topography. So devices you can have the Pentacam, the CS, the Scansys, the Galilei, whatever you have is good enough. So when and why do we need to do these scans is whenever you suspect keratoconus and when you're doing a refractive surgery. So the earlier concept was of Placido-based topography, and if you compare different machines that are there, that these are basically the OpScan to the Pentacam and the Galilei, whereas the Pentacam is the one which is the Schleimpflug imaging device along with Galilei, and the Pentacam is a single Schleimpflug, Galilei is a dual Schleimpflug, and the series is a single Schleimpflug with the Placido device. I'm also currently using, along with the Pentacam in another center of mine, I have the Scansys system, which is wonderful. And comparing these two scans, they both give good results. However, Pentacam is the gold standard, and therefore you need to compare your data with it. So how is Pentacam or these corneal tomographies, basically how are they different from the traditional Placido based or the scanning slate from the OrbScan? So the corneal, it's not topography, it is tomography that is being measured. So the primary source of data here is the measurement of the height. That is that the corneal elevation, the anterior and the posterior is measured, and the curvature is calculated on the basis of it. So a Pentacam has 5 things. So the Schleimpflug image, a 3D chamber analyzer, a cataract analyzer, a pachymetry, and a topography, making it 5 things. So a Pentacam. So the concept of that, you need to understand that the concept of the reference. So if you see the brightness of the cornea, the yellow is the cornea, and the reference sphere can be the blue color. It causes it to rise above the reference surface, resulting in the central hill, as you can see in the diagram on the right side as well. Now, immediately surrounding this is an annular C where the cornea dips below, and in the far periphery, the prolateness of the cornea rises above the reference surface, and this is where you see these peripheral islands. So color coding is very important when you're doing these readings. Remember, anything red means it's abnormal, it's going toward the hard, the larger, the bigger number, and anything blue is going towards the flatter side or the norm or the less normal size. It's thinner. So whatever you need to, a couple of things you need to exclude before doing these scans is a contact lens use, a misalignment, large angle, kappa, dry eye or excess tears, opacity or a scar, and previous corneal surgeries. These are going to give you erroneous data. So one thing is important: if you're using contact lenses for a soft lenses, 1 week you should avoid using it, and then you should do your corneal topography. And if it's a hard lens or a scleral lens, then you should be doing it after about 2 weeks. So this is what a Pentacam looks like. So there are a couple of things, I'll show each one in detail. You've got the QS, should be okay. You've got the Kmax, you've got the thinnest location here. You've got the y-axis deviation over here. You've got the anterior chamber depth, ideally should be internal. And then you've got the Q value. And then you've got your quad maps, the axial map or the sagittal map. Then you've got the front and the back elevation. And then you've got the corneal thickness map. This is the 11th you would see is what we call as the mean corneal thickness values, and then you've got the bad display. And then 13 and 14 would be the holiday EKR maps, and then you see the inter-eye corneal symmetry. So this is what a holiday EKR comes into this. And what you need to see is, I'll get into that detail a little bit later. So the QS stands for QS, that is the quality specification. It needs to be okay. It's a good scan. If it shows data or red color, it means the scan is bad and you need to repeat it. The Kmax should ideally be less than 47.2. And anything more than that indicates that it is towards keratoconus. May not be the case, maybe a steep cornea, but you need to still look at it more carefully. Thinnest location. So in keratoconic eyes, it's generally less than 470. So ideally it should be more than 470. A y-axis deviation should normally be less than 0.50. The anterior chamber depth is very important when you're planning your phakic IOLs, and it should be more than 2.8 or 3 millimeters. And it's the internal one that is more important, as seen over here, that is the external. So internal is more important. A Q value is about 0 to -1, and it's the measure of the corneal aspherity. I won't get into details of that. Sorry. Now let's look at for the quad maps. So you need to look for red, and this is an anterior map. You can see a symmetrical bow tie pattern over here, And then different shapes are also available. You can have a round shape, you can have an oval shape, you can have a symmetrical bow tie as you saw in the scan. You can have asymmetrical shapes like as the superior steepening, an asymmetrical bow tie with superior steepening, and inferior steepening, an asymmetrical bow tie with an inferior steepening, and uh, sorry for that. So this is almost a symmetrical bow tie pattern. And what you're seeing over here are the skewed shapes. A skewed axis is something which is more than 21 degrees. And basically, this is a symmetrical bow tie with a skewed radial axis. And this is an asymmetrical bow tie with a skewed radial axis. You can have some special shapes such as the butterfly, crab claw, or the kissing bird sign. You can have a vertical D, and you can have some irregular shapes or special shapes. These are seen in scars or previous surgery or with pterygium. Now look at the elevation map. So this is the front and the back. You can have central islands. You can have an hourglass pattern, as you can see over here. This is the BFS. Anything elevation maps for the front less than 12 is normal, and for the back less than 15. When it goes beyond 12 for the front and back more than 15, more if it's more than 15 for the front and more than 18 for the back, it's suspicious of keratoconus. Now look at the thickness map. This is with the y-axis deviation. You can also look at the x-axis deviation, which is the horizontal displacement. You can see the dome shaped over here. The thinnest location is out and diverted towards the the lateral side and the downside, and the y-axis deviation is much more. These are some special shapes, thickness in the thickness maps that you can see. A dome shape that you see in keratoconus, a bell shape that you see in case of pellucid marginal degeneration. Overall generalized thinning is seen in keratoglobus. When you're for the viewers, if you get a keratoglobus case to do a corneal tear repair, it's a nightmare. You cannot do it. The suture will actually run through it, like it will cause cheese wiring of the cornea itself. A 10-0 nylon will cause cheese wiring. I've done some cases. So basically, in the first case, I only realized if a keratoglobus case, remember, has a corneal tear, you need to do a keratoplasty. You cannot repair it. So thickness maps, this is the thinning that you see. These are anything in these thickness profile maps, anything on the red size that you see is abnormal or yellow is on the borderline, and you take a look at this. You don't need to remember the values. I won't get into too much detail. Now this picture is very, very important. Now let us look at these two things. There's a C over here, which is 0.1. 0.2 is here, and you look at two mountains, mountain 1 and mountain 2. Now if you're going to compare mountain 1 and mountain 2 from the reference, the baseline, which is at 1, the difference between mountain 1 and mountain 2 will not be that much. However, if that reference line is at point number 2, then the difference between mountain 1 in green and mountain 2 will be accentuated. And that is the idea of the bad display. And instead of a shape like this, you will get a shape like this, and the abnormal cornea is much more pronounced. So this is the idea of the Bellin-Ambrosio display. This is the best fit sphere on the first side. The second row is of the enhanced ectasia or the enhanced reference surface, and the difference between the two is on the lower side. And this is the front side, and this is the back side of the elevations that you are seeing. So if you're seeing in the picture on the right side, the difference gets accentuated in cases of keratoconus. So you can pick up early keratoconus with this. Now let's look at this scan. So look at this scan. This shows the K readings are absolutely fine and within normal limits. The scan looks generally fine. However, you have a K max of 47.9. And you have an asymmetrical bow tie with the superior steepening. Is my cursor also seen on when I'm sharing the screen? Is my cursor also visible?
Yes, yes.
My arrow visible? The thing
Yes,
that I'm showing?
You are visible. Yeah, we can see. Yeah, go ahead.
Yes.
Perfect. So you can see over here an asymmetrical bow tie with the superior steepening. The anterior elevation, okay, it's not so much in the central area, plus 14 here, plus 17 microns here. So not so much thinning. 510 microns is the thinnest location. The zero that you, or the O that you see, it is located over here. But if you see the bad display, this is accentuated. This is, even though you don't get your asymmetrical bow tie patterns, you don't get all of those classical things, this elevation indicates that this is a case of keratoconus. So next point is the EKR map. Now, the EKR map is very important when you're planning your toric lenses also. So any toric lens, that it be cataract surgery, whether it be phakic IOLs. In keratoconus, particularly if you're talking about this subject, if you get a peak like this or you get a tall peak, that is when the toric IOL will be susceptible, because you can use the toric IOL, I mean, and that is when, because it indicates that the astigmatism is regular. A toric IOL will not work if it's irregular astigmatism. So if you get something like this is not a fit candidate for toric IOL. Even if the cylinder value is about 8 diopters or 10 diopters, the patient will not benefit. So you need to do something to the cornea, which probably Ashraful will be talking about, the laser-based procedures to regularize the cornea. Now coming to some examples. So if you look at this cornea over here, you get, basically you're seeing an asymmetrical bow tie pattern. So you're getting the K value is also steep over here. The cornea is thin, the K max is thin. But remember one thing, I'll go back to this. So one of the early indications of keratoconus, a very early indication, is this asymmetrical bow tie pattern. So you need to look at this axial map very importantly and very correctly. You can miss, even if everything is normal, if it shows an asymmetrical bow tie with skewing, watch that carefully and do not do a corneal refractive procedure in such cases. So you see over here is asymmetrical bow tie pattern. You see anterior and posterior elevation, which is coinciding with the area of thinning. And this is basically, and the bad display also shows the same. This is a case of keratoconus. This is another example. You see there's asymmetrical bow tie here. K1, K2 is raised. The QS in keratoconic patients, sometimes high keratoconus, you have to understand the scan may not be very reliable. Okay, even in post-keratoplasty cases, this is the case. The cornea is only 361 microns and the anterior and the posterior elevation are coinciding. So is also seen on the bad display. So this is the case of keratoconus. Another example, you're going to see thin cornea, 493 microns, steep, Kmax is 53.8. You're going to see an asymmetrical bow tie pattern with probably not so much or skewing, maybe skewing, you can say. Anterior posterior elevation are there, which are coinciding. So here it is also keratoconus. Now let us look at this case. Now this shows all readings over here are normal. There's no, the thinnest location is fine, Kmax is fine. There's no elevation. But what you're seeing over here is a symmetrical bow tie pattern. So this, the bad display is also fine. So what is the diagnosis over here? It is with the rule astigmatism, because it is vertical, as you see here. However, if you get something like this is against the rule astigmatism. So this is a case where you will say oblique astigmatism. Okay, now let us look at this case. Everything looks
Dr.
fine
Karen,
over
we
here.
have to, because Dr. Khan, because
Sir?
of time, we have to make it shorter a bit.
Sorry, sir.
for
I'll
that.
just wrap it up in 2 minutes. I'll go through,
Thank you.
I'll just go to the last example. So let's look at this case. This is the last example. So if you look at this eye, I've operated this case. So this, if you see, everything looks fine. You see an asymmetrical bow tie pattern here, not much of elevation, no thinning that is there. Doubtful over here, can't say much, but maybe a suspect elevation over here. But you look at the left eye. The left eye shows asymmetrical bow tie pattern. There is thinning, there is elevation anterior and posterior. This patient came to me for LASIK. I did a topo guided PRK with a cross linking for him, and this is basically a keratoconus. So this eye would be a keratoconus suspect for the right, and left eye would be keratoconus. Another thing is the ASOCT, very important. The epithelial mapping is very important, and sometimes areas of hypertrophy are seen in cases of keratoconus. So it's a masker. To conclude, I would say early keratoconus detection requires a multimodal approach. Corneal topography and tomography are the cornerstones. ASOCT, especially epithelial mapping, is very important. You also need to look at the PACI when you're planning and the epithelial mapping when you're planning your topo guided procedures in such cases. Biomechanical analysis has a role. But I don't have too much experience about it. A detailed slit lamp examination is vital. Allergy profile is important. Age plays a role, and early screening in allergic and atopic individuals and cylinder values more than 2 diopters is very important. So you need to combine all of them, and timely diagnosis enables early cross-linking, preventing irreversible visual loss. Thank you to these guys who made this possible. Thank you again for this wonderful opportunity.
Thank you very much. I know it's the problem with the timing, because I know it's a big topic, but thank you very much for that.
Sir.
It's appreciated. So the next talk will be by Dr. Carmen Ramaznova. She will talk about management progress based on treatment pathway. It's all yours.
Good evening, everyone. Thank you for being here today.
Pleasure.
I'm Dr. Khuraman Ramazanova, and I'm working at National Ophthalmology Center in Azerbaijan. Today I'll be talking about managing progression of keratoconus. As was mentioned earlier, keratoconus is a progressive disease which is characterized by corneal thinning, stiffening, and by mechanical weakening. There are two main contributing factors, eye rubbing and reduced corneal biomechanical stiffness, and depending on the patient, one mechanism may dominate over the other. The cornea in keratoconus is significantly thinner and weaker, and approximately 60% as stiff as a normal cornea. And we see in keratoconic cornea, we can see increased collagen breakdown, loss of keratocytes, reduced in interlamellar adhesion, and weakening of Bowman's membrane. In the management of keratoconus, early detection is essential. The earlier we identify keratoconus, the better our chance to slow or halt progression and preserve visual quality. Management includes slowing progression using corneal cross-linking, improving vision using glasses, contact lenses, ring segments, and other surgical options. And further, we have to monitor changes. When other methods are no longer effective, corneal transplantation becomes necessary. So before moving forward, I want to emphasize that eye rubbing is the main modifiable risk factor for keratoconus progression, and managing ocular allergy and avoiding rubbing can significantly reduce progression, acute eye drops, and post-keratoplasty complications. Now, let's move to corneal cross-linking, which is our key evidence-based treatment to stabilize keratoconus progression. It has excellent safety profile proven in adults, and it makes the cornea stiffer by creating additional cross-links between collagen fibers through riboflavin and UVA light. At this point, I want to briefly recap the photochemical mechanism. UVA light at the wavelengths of 365-370 nanometers activates riboflavin, which generates reactive oxygen species and creates new collagen bonds. This increases stiffness of cornea by up to 3 times and reduces corneal stiffening and increases central flattening. There are two phases in cross-linking: aerobic phase, which is oxygen dependent and is more efficient, produces strong cross-links, and anaerobic phase, which is oxygen depleted, slower and less effective. And in conventional cross-linking, it is mostly aerobic, which produces stronger biomechanical stiffening. Accelerated cross-linking is mostly anaerobic, especially when irritance exceeds 15 millivolt centimeters squared. What are indications? Indications are keratoconus with documented progression. Pediatric patients, the document progression is not required because as early we intervene, the better will be outcome. For iso-osmolar cross-linking, 400 microns. For hypo-osmolar cross-linking, 350 microns after epithelial debridement. Contraindications are corneal thickness less than 350 microns, severe central scarring, severe dry eye, prior herpetic infection, concurrent ocular infection, autoimmune disease, poor epithelial wound healing, riboflavin allergy, and pregnancy. So what is progression? When visual acuity decreases by 1 Snellen line or more, when increasing in cylinder on manifest refraction by 1 diopter or more over 1 year, when the steepest keratometry and Kmax increases by 1 diopter or more over 1 year, and a progressive decrease in corneal thickness. In 2015, the Global Delphi Panel of Keratoconus and Ectatic Disease showed that progression may be a constant change in at least 2 of the following parameters: progressive stiffening of the anterior surface, progressive stiffening of the posterior corneal surface, or progressive thinning of the Sorry. I'm sorry.
No problem.
Yes. Let's talk about conventional cross-linking. It was first described by Wollensak et al. From Technical University of Dresden in 2003, and it was using riboflavin and ultraviolet radiation. What are steps? After topical anesthesia, removal of the central 8-9 millimeters of the epithelium, riboflavin 5-phosphate was applied for 30 minutes, for every 2 to 5 minutes. And after that, exposure to UVA radiation for 30 minutes at 3 milliwatt centimeters square. And after application of topical antibiotics and contact lens. Accelerated cross-linking is based on the Bunsen-Roscoe law, meaning that same total energy can be delivered with high irradiance and shorter time. And there are different types. So you can use 9 milliwatt centimeter squared for 10 minutes or 18 for 5 minutes. But very high intensities over 45 milliwatt didn't increase biomechanical strength and doesn't improve outcomes. There are meta-analyses which compared standard and accelerated cross-linkings, and it showed that standard cross-linking was superior in MEOM K, and there was a deeper demarcation line, but there was no difference in terms of uncorrected, best corrected visual acuity, spherical equivalent, K average and maximal biomechanical properties, reptilization, endothelial density. Another study by Nikula showed a 5-year follow-up. It showed also similar visual and topographic outcomes. Another study by Medeiros, it was 1-year follow-up, which shows that accelerated cross-linking is safe and effective, but flattening was more in standard cross-linking. So we can compare that in conventional or standard cross-linking, there is proven efficacy in most studies, time consuming it, more patient discomfort because of time, and excessive corneal dehydration. But in accelerated, there is less surgical time, improved patient comfort, and lesser risk of infection. I just want to show the classification of cross-linking. By epithelial management, it can be epithelial off, on, and partial epithelial removal techniques. By UVA irradiance, it can be conventional and accelerated. Then it may be also by riboflavin delivery standard, iso-osmolar riboflavin, which is using dextran-based, and dextran dehydrates stroma. Hypoosmolar riboflavin for thin corneas, dextran-free, HPMC-based. Then by clinical indication, it can be for keratoconus, for post-LASIK PRK ectasias, for infectious keratitis, refractive customized cross-linking, and also prophylactic cross-linking when it's used with LASIK and PRK. And also, as other surgical procedures, it also has its own complications as temporary stromal edema, temporary haze, and permanent haze, corneal scarring and sterile infiltrates, infectious keratitis, and diffuse lamellar keratitis in the post-LASIK patients. Thank you for your attention.
Thank you very much. That's very good. Cover all aspects. Regarding the next talk, and then we're going to have the discussion. So it's a pleasure to have Dr. Ashrafil Haq, who talking about restore vision in keratoconus, surgical decision, and making journey. It's all yours, Dr. Ashrafil.
Good evening to you all. My screens are visible and I am audible?
Yes.
Yes, Dr. Ashraf.
Yeah, thank you very much. And thank you, MEOM Academy and Professor Amri for having me here. So restoring vision in keratoconus, the decision-making journey, this is a very important. And why this is very important? Because the rising global prevalence of keratoconus, and now that we know that patient populations are the younger, and the vision and lifestyle impact is very important for them, and also the importance on appropriate intervention is very much needed. So the decision making for the vision restoration is very important, and we all know that treating vision for the keratoconus is not that much easy because of irregular astigmatism, higher order aberrations, optical zone distortions, and effects of visual acuity in each stage of keratoconus. So we need to think carefully how this keratoconus patient can regain his vision and he can actively gain the optimum corrected vision. So two goals. Now, first is the progression. If the keratoconus is progressive, we need to first stop the progression, and my previous speakers, Dr. Karan and Dr. Khuraman, has greatly speak about the progression, detection of keratoconus, and when we stop the progression, then the next goal is the improve the functional vision. So this decision making, why it's important, because when the patient of keratoconus comes to us, first of all, there is the patient complains that I want to gain my vision, but we need to make the patient understand that first, we need to stop the progression. Vision is not first. The progression management is the first. And also the keratoconus patient has lots of ocular and associated manifestation. We need to treat them also. And when the keratoconus becomes stable, then we go for the visual rehabilitation. So the non-surgical visual rehabilitation options include the spectacle. When we can give the spectacle in very early keratoconus with minimal irregular astigmatism, the staging of keratoconus, early, moderate, and severe and advanced keratoconus, I'm not going into that. I am just going into the how we can do the visual rehabilitation. So the spectacle is the first option for the visual rehabilitation in case this keratoconus is very early. But the thing is that if the progression is there, even if after the CXL the progression might happen, so the visual distortion can occur. And then what we can do, the soft toric contact lens. This is also for the early keratoconus, but with the regular astigmatism, because the soft toric contact lens has the limited ability to neutralize the irregular astigmatism. So patient won't be happy if they have the irregular astigmatism and we prescribe the soft toric contact lenses. And the RGP lens for the moderate keratoconus, it works well, but the size of the lens, they have the patient has the comfort issues and the lens decentration and the steep cones happen. So majority of the cases for the RGP lenses, patients feel discomfort. The scleral lens, these are the best current option for now in the advanced keratoconus, even after the CXL and the post keratoplasty. I shall come in details of the scleral contact lens in my next slides, but the disadvantage is it is pricey. The cost, and also the patients have the severe keratoconus and ocular surface disorder. The pros lens are very good, but it is not available in all the centers. It is available in the specialized centers, and it is the most expensive things. So these are the non-interventional visual rehabilitation options, but not all patients are suitable for that options, the interventions. Some patients, we give the contact lenses, some patients are the contact lens intolerant. So the options of the contact lens intolerance patient could be, one is the intracorneal ring segment. But the intracorneal ring segment, the measurement and the patient selection should be very careful. The gross basic things is that the central corneal thickness more than 400 micrometer at the tunnel, no corneal scarring, and the Kmax below 60 diopter. This is the likely moderate keratoconus, but the identifying the cone is the most important part. And sometimes the ICRS can improve the vision, but it is not cure the keratoconus. So in the progressive cases, we do the CXL and the ring segment. And if the patient is myopic and they have the refractive error, so the mild to moderate keratoconus, we can go for the topo-guided PRK with CXL. But we need to have the sufficient corneal thickness after the ablation. So calculation need to do before. It helps the regularized cone, but the patient counseling is very important here, because the patients are young patients and some patients have the unrealistic expectation, because the topo-guided PRK and CXL will improve the quality of the vision and improve the best corrected visual acuity. It will not give the patient freedom from glasses or freedom from contact lenses. Tachycardial, this is the one of the thing. This is recently it has the patient with the myopia and the stable cornea. After CXL, if the anterior chamber depth is adequate and if there is no corneal scarring, the ICL is one of the very good option for the high refractive errors, specifically if we which have the residual refractive error mainly spherical. But also we need to counsel the patient about the residual cylinder power after the ICL surgery. But many patients and are the very happy after CXL and after the ICL implantation. And the last option is the keratoplasty. So keratoplasty, the cornea transplantation indications are the severe thinning, corneal scar, contact lens intolerance, and the visual disabling irregularity and not correctable by other means. I cannot improve the vision by other means that is still above. And the options of the keratoplasty are mainly DALK and the penetrating keratoplasty. The DALK has the less rejection risk, but we need to have the healthy endothelium, DALK giving the long-term stability. But penetrating keratoplasty, if there is a deep stromal scarring or patients have the hydrops or the Desmond break, we should go for the penetrating keratoplasty. And deep anterior lamellar keratoplasty is a very good option for the advanced keratoconus and severe keratoconus patient because it gives the long-term graft survival and safer surgery. But the DALK, most of the surgeon need to be expert because there is a perforation chance. Then we need to go to convert to penetrating keratoplasty, and there is a less chance of postoperative glaucoma and cataract. And also we after the PKP we know that the patient develop cataract. So in DALK there is a less duration of steroid, so steroid-induced cataract risk is less. And the penetrating keratoplasty, we go for the advanced keratoconus, hydrops or scar. If there is a failed DALK, then we can go for the penetrating keratoplasty. And also when we go for the decision for the penetrating keratoplasty, that the patient has the poor visual, best corrected visual acuity with the contact lenses, and surgical consideration of this, we have the donor size should be adequate, host refination not too large, and the suturing, we can go for the interrupted suture or the continuous suture. The surgical rehabilitation in penetrating keratoplasty and the deep anterior lamellar keratoplasty, though the deep anterior lamellar keratoplasty gives the more graft stability, but this is the question to the expert panelist for the discussion, that in our observation, the penetrating keratoplasty gives the better visual outcome to the patient rather than the deep anterior lamellar keratoplasty. And the final visual rehabilitation, because after the keratoplasty, the patient develops astigmatism, and most of the patient after the suture removal, they also need the scleral contact lens. This is the best option and the final option for the visual rehabilitation after CXL, after keratoplasty, or by any means. The patient has the very good visual outcome after the scleral contact lens. And we have our own study that with the other keratoconus patient, though the patients went for CXL, after CXL or the post keratoplasty patient, after the 6 months, if we trial them with the scleral contact lens, the visual acuity is significantly better with the scleral contact lenses. So the restoring vision in keratoconus, the main thing is that early detection is the key. If I can diagnose keratoconus early, which stage the keratoconus is, the treatment plan becomes easy. And CXL remains the foundation of halting the disease. Vision restoration is stepwise, not one size fits all. Not CXL is for all, not contact lens is for all, or not keratoplasty is for all. We have to treat the biomechanics first and the optics next. So visual rehabilitation is the last after stopping the progression. ICRS can reshape the cornea. It is not curing the keratoconus. And topo-guided PRK improves the quality of the vision, not the quantity of the vision. And the phakic IOL is for the high refractive error, but it has the residual cylinder refractive errors. And the keratoplasty is the last step for the visual rehabilitation. And at last, the scleral contact lens is the key for the right now for the visual rehabilitation, restoring the vision journey. Thank you for the patient hearing. These are my involvements, and I'm happy to share the discussion regarding the visual rehabilitation of the keratoconus patient.
Thank you very much, Dr. Ashfel. That's a great talk. So I just will join our panelists now with us. And if any panel want any comment about the first talks.
First talk, but I start with a comment, with a congratulation for the first talk. Was very complete, but I think that about the etiology, the key word actually is in the definition, the new definition. You know that I am in the second Delphi panel. So keratoconus actually is defined as a multifactorial disease. So the key word is multifactorial because we know a lot of mechanisms that cross genetics aspects with environmental inflammatory proteases. So this is the keywords, multifactorial. And I think another important aspect is also what is emerging not only in inflammation pathways, proteases, metalloproteinases imbalance, but so biomarkers-driven diagnostic approach, studying the biomarkers of the ocular surface and the tear films, but also the relationships between hormonal status of the patients according to the onset, to the progression, and to the proteomic state of the ocular surface, but also some news are coming from the study of the ocular microbiome. The ocular microbiota could play an important role according to ocular surface proteomics and metabolomics. So there are a lot of things to discover. So congratulations for the talk about the keratoconus etiology. But the key word actually is multifactorial.
I think in our region, by the way, here, it's very high, and I think genetics play a big role on top of the Arabic, but genetic is big factor.
Yeah, absolutely. We know that there are a lot of geographic differences, no? So this is an important observation.
Any other comment from other panelists, please?
I also want to highlight on eye rubbing. So eye rubbing actually comes in two forms. So one is associated with the allergy and the other one is the habitual eye rubbing. So we need to see what kind of eye rubbing our patient has. So if it is associated with allergy, we definitely have to address the allergic part. And if it is habitual, we need to make sure that we need to explain to the parents of the children. So to avoid eye rubbing and, to bring down the habit. So we need to, address these two different things about eye rubbing. That's very important aspect.
It's very important to treat people with allergy also to reduce this
Yes.
inflammation.
Yes.
The vigorous eye rubbing is something that we need to address.
Any other comment?
Just if I can have another message for patient and for family, because we have to have the good manner to talk with patient and family. And in my practice, I try to say with the patient and family to make simple message. There are many factors inside the eye, and there are many factors outside the eye. And this multifactorial approach, we can give clear idea with us what is happening in the eye and what is happening in outside the eye. It's like general disease. And another message for patient and for family, we can't stop the disease, but we can never remove the disease. They have to keep in mind this is a chronic disease. And these two messages, it's very didactic, both for young residents, for ophthalmologists, and for family also. To keep in mind, there is something inside the eye, inside the cornea, and even disease in the cornea. This is many other factors outside the eye. And this is the key message to give to the family and for the patient also.
Yes.
Also tell the family that the screen, anyone with the family wearing glasses, to have to check for keratoconus. All of them, they need to have corneal tomography to check anyone had keratoconus. I think the family need to be screened, all of them.
Yes, and another message, we can stop, we can improve the vision, but we can never remove the disease. This is for the life, for the life.
Regarding the second,
Another important aspect about in the etiology that I have not here in the presentation is the role of vitamin D. Vitamin D
deficiency.
Insufficiency is another important and critical role that may play an important role in the etiology as a systemic factor of the disease. So we have a lot of deficit in vitamins. We have reduced levels of vitamin D. We have reduced level of vitamin B2. Riboflavin itself. We have a lot of deficiency of copper, zinc, and some minerals that are important. So keratoconus should have an holistic approach, also as a systemic disease. Patients should be screened also for vitamin D insufficiency, for hormonal status, thyroid status, and everything is important in the treatment, not only cross-linking itself, but also the holistic approach by a systemic point.
The other things, second talk about diagnosis. Does all of us using milipenticam, or most of them move it to OCT based like MS39 for the diagnosis?
So I have another keyword. The first keyword for the first talk is multifactorial, no? While for diagnosis is multimodal. This is the second keyword of the webinar. So, you know, I think, Mushin, you are agree.
Yes. Just to add another thing, it's multimodal, multifactorial, and multi-layers.
Yeah.
Multi-layers. Disease. In the past we thought that is in the stroma. It's mistake. Maybe we should keep about epithelium. What's happening in epithelium? And so it's multi-layer disease also.
Yes, I
Yes.
agree.
Yes, it's true.
Yeah, talking about the investigations, that's what like people we do all. You are mentioning about the analysis. I think to know the vitamin D level, and also you talked about. I think we do all the investigations like pentacam and other this thing. But the few investigation, there's what tear film analysis. There's what been my friend Dr. Rohit been started doing. The machine is yet to come. Tear film analyzer. So the tear film analyzer, it will find out the different levels of interleukins. It is different levels of IL-6 or whatever the kinins and other factors that also definitely play a different role in keratoconus. I think everybody do agree with that. I think once that machine comes, tear film analyzer, you take from the strip tear film, then subject it for the different investigation. I think exact diagnosis is going to have, and we are going to tackle them in their early stage only. That is what my personal feel.
I think we need to listen to
I have a small question to the first talk. The first presenter, I have a question. Do you think MMP9 is inflammation? Do you think that this factor is very important in the diagnostic of the keratoconus, or the keratoconus is more degenerative? Is it inflammatory or degenerative? What is your opinion?
So the new researches are all highlighting that it is an inflammatory disease. Yes, so it is inflammatory.
You think like this?
Yes.
It's a very good opinion.
As we discussed earlier, it's multifactorial. So inflammation play part, but not the main. I think is mixed. But I think it's good if you do benign and high. This patient need to be treated as inflammation part. But if keratoconus and you do benign and there's no inflammation, maybe you don't need to consider as anti-inflammatory treatment to quieten the eyes.
I think that in Florence, during the meeting, Artashes will be in the panel. We will discuss about biomarkers-driven treatments.
Excellent.
Yes.
So we are changing our mindset about not only about diagnostics, so the biomarkers identification in the tear film, but also according to these kind of pathways to identify which is the best treatment option according to the biomarkers present in the ocular surface. So it will be a very interesting field to be discovered. Yes, about the diagnostic that is now multimodal, I suggest to not recommend axial map, but only tangential maps algorithm for keratoconus. And I have not here mentioned about eye gorder aberrations. The study of eye gorder aberrations that are very sensitive in progression, in detection and progression, and together with the epithelial mapping, as Mushin told before, is very important for diagnostic, multimodal diagnostic, and also biomechanics, of course, and also biomechanics that was not mentioned in the talk is another important tool for early diagnosis. I hope that very soon we will have the Brilloin microscopy helping us to define the corneal biomechanics in the study of the elastic modulus of the cornea. Okay.
So the next one about cross-linking. If she had pregnant and progressive, do you do cross-linking or not? The panels. A patient, 25, for example, and she's pregnant, and their keratoconus progress. Do you do cross-linking while she's pregnant or not?
Pregnancy is included among the contraindications of cross-linking, but generally I do before.
She's already pregnant now.
Yes.
But when she's already pregnant, I prefer to avoid because we don't know about teratogenic effect of this therapy. I don't think that we have a teratogenic effect. So I think it is not a real contraindication. It's a defensive contraindication for potential legal claims, but I don't think that there is.
Me too, really.
I agree with you, and I agree with you. Another thing, that's we have to pay attention that to make a difference between progression and pseudo progression, even in pregnancy, because in pregnancy there is some modification sometimes in the cornea, and the mistake here, which will be double. That's we try to speak about progression. It's not true. And another thing, we don't have any idea about teratogenic effects. In my opinion, I will never do a cross-linking in pregnant women ever, because in our practice we see the patient and we have time about 6 months to see the patient and to see you later, except if we have a really very advanced keratoconus, and this situation, like my dear Professor Mazuta, I maybe to do it before, and I ask the patient, she have children or not, both in refractive surgery, always I have this question. What about the family? She need to be pregnant or not in 1 year, in 2 years?
The other thing is just interesting about the cornea thickness for the panel. What's the thinnest cornea where you say, no, I'm not going to do cross-linking if the patient has still potential good vision with contact lens? Do you have a cutoff for the thickness, or if the patient happy with the vision, then you do cross-linking? And you can use different protocol, I mean, okay? And what protocol everyone using for thin cornea?
Let me ask the question to the second speaker, maybe second, Dr. Ramazanova, about the protocol of cross-linking. Yes.
Yes.
What is your opinion? Which one is the safer? We have femto cross-linking, we have Smile Extra, we have different kind of cross-linking therapies like Attens protocol, etc. What is your opinion? Which one is the safer? And how can we treat keratoconus the best way? Epi-on, epi-off, we have many options and protocols. For the first keratoconus diagnosed patient with maybe with refraction, what is your opinion, boy or girl, 22 years, 23 years old? What is your opinion to do like therapy with refractive or epi-on or epi-off? What is your opinion about the protocols? How do you think?
So there are types epi-off and epi-on, but
epi-off,
if you
epi-on, Smile Extra, femto cross-linking, or different kind of cross-linking
there are additional
protocols.
procedures. Yes.
Yes.
There are additional procedures.
Yes.
But if you want to stop progression, you have to do either conventional or accelerated cross-linking. So
Yes.
if you are doing epi-on cross-linking, there may be issues with penetrations of riboflavin. So we have to use epithelial toxic agents like ETA or benzalkonium chloride. So they will lose this epithelium. But the efficacy of this procedure may be less than epi-off.
Good.
Yes. So
Also
the best is epi-off for, yes, I agree with you. This is, of course. Thank you.
Thank you.
Let me say just one thing for the third topic that was about progression, because you know the new definition of progression is changed in the second Delphi panel. This is a spoiler because we are going to publish it in Cornea in I hope in the next 2 or 3 months. You know that there is a consensus about 92% of consensus that Kmax has low repeatability. So Kmax is not used anymore as anterior curvature change, but anterior radius of curvature is more reliable. So actually the new definition of progression is changes, measurable changes in the anterior and posterior curvature, thinnest pachymetry variations, and association with visual acuity decay. So the anterior curvature is lacking of meaning according to the less repeatability of the Kmax value in the new progression definition. Let me say also about the protocols of cross-linking. It's correct, Artashes, we have a lot of protocols, so we should indicate the protocol according to the clinical case that we have. So if we have a pediatric patient, we have now consensus about epi-off, only epi-off use in pediatric population.
Agreed.
And also without waiting for progression, but at first time of diagnosis. And we can use both the Dresden protocol, but also the accelerated 9 milliwatt protocol that is actually the most used, internationally used protocol in EPIOF. Of course, we have the possibility to introduce riboflavin by iontophoresis, riboflavin loading, not only by enhanced riboflavin solutions with ADTA or benzalkonium or trometamol, alcohol, anesthetics, drops on the surface. And we are using also in EPION Eiger fluence protocol and pulsed light and a supplemental oxygen are all the compensatory mechanisms that are increasing the efficiency and efficacy of EPION strategies that I think in the future will replace the EPIOF protocol. So we are going in a new era of cross-linking, I think, from accelerated to new EPION strategies with different level of compensations. Okay.
I have comments about the progression criteria. If we think about what's happened in the cornea, the turnover of the cornea, and we know the turnover of about tears, it's around 7 seconds. The epithelium, 7 days. The stroma, 7 years around. The rule of 7, 7, 7, 7. In keratoconus progression, we try to assess what's happened in the stroma. We know that the turnover in stroma, it's not to speed. I think the answer in the future will be in biomarkers or in epithelium, because it's more speed, what's happened in the cornea. If we wait what's happened in the stroma, we'll wait more time and we can diagnose as soon as possible the progression. I think I agree with you that the new era, it's not in the stroma. The stroma, it's the consequences of the disease. If we try to diagnose soon, we have to take a look about what happened in the epithelium and lacrimal tears, that's in biomarkers. I agree with you, that's the new era, it's not, and I agree with you totally that a pentacam really have many, many weak points about pentacam. It's not good tools to make diagnosis for early keratoconus. And it's not good also for advanced keratoconus. Since we have scars, the pentacam, we can't use it. Really, we can't use it. So we can't trust this. And really, we have to talk about OCT. And I saw in some slide about the thinnest point. Really, we should forget the accuracy about thinnest point in the pentacam. The thinnest point is OCT. And when we do rings, we have to take into account where is the thinnest point. And where is the thinnest point? The OCT, it's more accurate than pentacam.
Sure. Correct. Perfect.
Regarding
Yes,
the last topic about surgical option, about one thing is about phakic implant. I think it's very important the patient have useful vision with the glasses. If he cannot see clear with the glasses, the phakic implant really it shouldn't be implanted. And still, as you can target not only sphere, I think the astigmatism is very powerful also, but need to have consistent astigmatism with different measurement.
I totally agree with you. I have some comments about this phakic IOL. When we talk about phakic IOL, we should keep in mind we are talking about low order aberration. It's very important. Phakic IOL, we can't correct anything about high order aberration. And another comment, we should pay attention that the anterior chamber depth, it's irregular. And if we try to put toric IOL, maybe the rotation, the stability, it's not sure. So the message, never, I think in my practice, never toric phakic IOL in keratoconic patient. And we have to focus about spherical aberration only. And I agree with you, that's mean good visual acuity with spectacles.
I agree.
let me give some my point of view. So we have to distinguish what is the treatment of keratoconus and what is the vision correction. This is the different things. First of all, cross-linking is the treatment of keratoconus. First of all, then it can be Kera rings, cares, phakic and different kind of technologies. And we should pay attention on this. First of all, treatment, then waiting and correction. This is my point of view for young generation, my recommendation, because simultaneous treatment is not precise treatment. It's not precise. So first of all, treat, then wait 6 months, then correct.
That's a different challenge. I'm going to put it to the panel. If someone had poor vision, he cannot read contact lens. I usually other way. I do the ring first, then to do cross-linking. So I don't do cross-linking, then I'm thinking this patient can fit the contact lens or no. So always if I had contact lens, poor vision, I'll go for contact lens. If he cannot read contact lens, I do rings, then I do cross-linking.
So what is your opinion? Do you think that Kera ring is stopping progression of keratoconus or not?
No, not to stop. No, it doesn't stop. But the effect of the cross-linking, many studies show maybe less if you do cross-linking first.
So this is very challenging question. Yes, this is very challenging question.
So if you're going to do both, you know this patient, he needs the rings and he needs the cross-linking. You need to do the ring first. Then after a month or two, at least you know the effect of the rings. I don't like to do the same time. I want to see this ring will benefit this patient. Then a month through 3 months, I'll do cross-linking. But I don't do cross-linking, then I'm thinking what I'm going to do next.
So there are many options. And if the surgeon is good, you are well, and you are good, why not?
Any other comment from other panel? What do you do if you patient have, he need rings and he need also cross-linking? You do it the same time or you do an order and what order?
If you take a look to the literature, data, there is no statistically significant difference in the results between simultaneous application of combination of rings and cross-linking versus the sequential application, ring first and then cross-linking. These are the data in the literature. I also prefer to do separately, so to put the rings first, then wait the maximum effect of the rings in a softer tissue, of course, because the cross-linked tissue is less soft. So I think that if we want the maximum effect of a ring, we should put the ring before cross-linking and then cross-link the cornea after 3 to 6 months. But the literature data are absolutely in favor to simultaneous cross-linking and ring application. I have a comment. Yes, the cares were not mentioned by Dr. Asherful. I think, yes, it is a new option that is growing popularity. And I think actually is still off-label. So it is just for more advanced cases of keratoconus, and it is not in competition with PMMA rings, in my opinion, actually. But what I want to comment is that you mentioned in your talk that when you do a topography or ray tracing guided or wavefront guided PTK or PRK plus cross-linking, you improve only the quality of vision. I don't think so. You improve both the quality of vision, but also the quantity of vision. Because if you go in the literature, you have a lot of long-term studies published by John Canellopoulos, by George Kimionis, and also by myself with the ray tracing technology, that you can see that the gain in terms of uncorrected and best spectacle corrected visual acuity is about 3 lines, more than 3 lines in 45% for the Athens protocol. But if you use ray tracing technology, that is the modern technology that we are using, you have an average gain in terms of quantitative vision, about 70% of patients gain around 5 to 6 lines more. So you improve the quality first, of course, because you reduce the aberration, the high order aberrations. So you transform an high order aberration in a low order aberration that is more susceptible of spectacle correction. But you have also an effect on quantity, not only in quality, but also in quantity.
I have two questions to ask. First of all, I want an input on the bone marrow transplant for the contact lens tolerance. And second thing is I want to ask about the size of the tissue that you guys are using in doing a penetrating keratoplasty in the corneas, which are very, very thin. Like if the cornea is around 100 microns or less than that, what is the size of the donor tissue that you use in that case? Is it a standard size or you use about 11 to 12 microns?
The size depends on the cone. Where's the cone and the thinness? You have to include all the cones. So it's good things to look into the flessuring and look very careful. Where's the thickness and where's the so you have to always enlarge the graft according to how much is the advanced the graft and how much periphery. So you need to include the ectatic cornea in the graft. You cannot leave any ectatic thin cornea outside.
So if the cone is very close to the limbus, suppose inferior limbus, and what is your treatment plan in that case? Because the sutures are going to just cut through the host tissue if it's very thin. So should we be using a bigger size
globus, you have to enlarge it. Yeah,
or
you
even,
have to include it, but always try to do that.
Or even in the patients with keratoconus, at times their cornea is very, very thin. Like you can see the cut through with the needle of the suture. So should we be using a bigger size graft in those cases? And I also want an input on the bone marrow transplant in the cases of keratoconus, where we just need to improve the contact lens tolerance.
One of the panel, you want to take that question? So basically, cornea graft, you need to include all the cornea, weak cornea. You cannot leave weak cornea. And then you can do, always try for larger graft, you try to do as much deep lamellar. You don't want to do penetrating for this graft. You need to be very delicate and try to as much safe not to go for penetrating. Some people even do a big dark and do, and there is even scar in the center, they do another graft over it, but allowed to heal. Because if you leave any remaining of keratoconic thin cornea outside the graft, this patient will have very high astigmatism and regular, so you're not going to have a good vision. So it's a balance. It's very careful about it. But technically, anyone who had keratoconus, you need to remove all the thin ectatic cornea. Any comment from other panels?
Just small comment about when we talk about topo-guided or wave-guided. I think if we have the chance to make diagnosis in moderate cases, in this situation, really, I prefer to do wave-guided. Why? Because when we do topo-guided, combined to cross-linking, of course, we take into account only anterior surface aberration. In comparison with wave-guided, we take into account both what's happened in the anterior surface and posterior surface. And we know there is like compensation what's happened in the anterior and the posterior. If we treat with topo-guided only anterior surface, there is two mistakes. The first, we didn't take into account what happened in the posterior, and we know the comparison between virgin cornea and keratoconus cornea, the posterior surface in keratoconus cornea play big role what's happening in keratoconus. So my message, if we have the chance to diagnose moderate cases, that's mean CAMAX lower than 55 and the pachymetry around more than 400, we should prefer, without no doubt, wave-guided treatments in order to do topo-guided.
Problem sometimes with moderate keratoconus, the wavefront measurement not as accurate, and that's become more challenge. So which machine using, by the way? Now, most of the new machine now, they're not good wavefront guided anyway.
Yes, I use MS-39. I have the chance to have many tools to use, and I can measure what's happening in the total corneal aberration and anterior. And by extrapolation, we can calculate what's happening in posterior surface. That's why I highlight, especially for moderate cases. For advanced cases, the aberration it's not accurate totally.
Any input about the bone
Any
marrow
more questions?
transplant? Any input on the bone marrow transplant? So we have done a number of cases at our setup, but the cost of the procedure was very high. But it does increase and improve the contact lens tolerance. So do you have any experiences with that, with the bone marrow transplant?
And what contact lens intolerance? What type of contact lens this patient you had?
Scleral contact lens. Sorry, the rigid contact lenses.
Yeah, the problem with this, because we're using a sclera, and I don't think it's anyone had fitted sclera, the Bowman transplant will make it different, I think. So I don't use it really. But is because the sclera will cover it, even if you do Bowman, it will not make it too flat to make it better fit for sclera contact lens. Any other comment from the panels?
Yes, I want to
Bowman
add.
membrane?
I want to add about the scleral contact lens. They are work very well, and of course
Yes,
they
they do.
improve eyesight. We should consider it, but not everyone want this. Majority of people, they don't want this. They want Kera rings, they want pachycioles, and in these cases, we should do this first. Then, if not, going to scleral rigid contact lens. This is an option. This is not for everybody. The majority of people, they don't want this. This is a very special thing.
I think it's
Sure,
just the learning curve. It's just a matter of time where they learn to put it and remove. So once they're comfortable with using it, I think nothing like it. The quality of vision that it gives is excellent.
Quality of vision, of course, yes, I agree with you. But for ladies, yes. For men, maybe not for everybody. This is a specific thing, and that's why we are most using cares or Kera to improve eyesight and to get rid of contact lenses for glasses and these kind of things.
But the one thing I want to address that the improvement of vision after stopping the progression of the keratoconus, the scleral contact lens, the how much comfort and the clearance or clarity of vision they give. The ICL, definitely, if the ICL, the patient has not the high astigmatism, the ICL are good. But the quality scleral contact lens is better than ICL and clears and Intex other procedure. That video.
Let me answer. Let me answer you. Let me answer
Dr.
you.
Aparna and Dr. Ashraful have said. And the thing is, see, you need to understand the role of aberrometry here. So, a keratoconus eye will have a lot of higher order aberrations, and I don't know if that was discussed. So, I have an aberrometry device in my clinic. I use the Scansys also in one of the centers, as I had mentioned in my presentation. It has a device. It shows you when you look at the aberrometry map. It will show you what is going to improve with phakic or not. Care rings are different, yes, but sometimes non-intervention is the way to go. You can go for whatever way. I'll answer in a diplomatic way that you can go for the rings, you can go for all those cares, you can go for skill lenses, but sometimes a non-intervention way is something that the patient really likes. And yes, I would second what Dr. Aparna and Dr. Ashraful has said, the vision do you get? I always tell my patients there'll be a wow effect. If it works, you've never seen like that in 15 years, in 10 years. So you should never forget the use of scleral lenses. They are very, very, very important, and you should have a very good person who's doing it properly.
And also the
One
education,
comment
how to
about
use
it.
it, and
One
being
comment here,
comfortable
by
to
the way.
use the scleral lens is very important.
Yeah, one comment because when I move here from UK, I move it to here, and initially people, oh, this is Dubai dust environment, we doesn't. But I always encourage the patient to try. Once they try and see very clear, they're the one insisted to keep and to order the lens. So always try to convince the patient just try first. Because once they see very clear, that's big motivated to carry. But if it's from start, oh, I don't want to put the lenses, or this is dusty environment, then you'll put him down from before he starts. So always push him, just let him to try. And really, bro, really, once they try, they see very clear, that's become very motivative, and suddenly he wanted. Any comment? Almost we going to close soon. So any comment, any question, please?
I have another question to the expert panelist that regarding the keratoconus, advanced keratoconus with the post-DALC and post-PKP. Always the thing, I don't know, this is in my practice, the how many DALC and PKP I given to done to the keratoconus patient. The post-PKP visual outcome is better than the DALC. So do you have any comment about this?
And
Ashraful, I
Doug, is
don't
it you
agree.
do big bubble or what's technique? The bigger the
Big bubble.
Doug?
I don't agree, Ashraful. So DALC has got excellent
Yes.
outcomes.
Yes,
So
that's I saw everywhere. But in our practice, in our center, we have done studies that I don't know post-DALC versus post-PK. The post-PK visual outcome is better than the post-DALC.
Does
fine,
your
what
patient have some
That's right.
some haze interface or something or not?
No,
The patient you had this not happy with the vision. They have some haze interface or anything
no, sir, no, sir, no
particular?
hair interface.
And because the
That-
study is very close, maybe it's tiny bit, one line better maybe, but not much. So patient doesn't go to complain.
Yeah, not much, but yes, you are right.
Very
The
tiny,
line
maybe some
difference is
people
not
reported
much, but PK
one line
initial
less.
better. Yeah.
Ashraful, what is the number of patients that you're talking about here?
I'm talking about like last year we have done like 60 to 70 DALCs and nearly, I'm talking about the keratoconus patient and nearly 150 PK. So the thing is that we got the outcome within first 3 months. Post PK patient has the better outcome in the keratoconus rather than post DALC.
What
But
is
it could
the
be,
outcome criteria? Is it the BCVA or is it the UCVA?
this is the UCVA.
So the thing is, you need to see the BCVA, and I feel a role of suture management is quite important here. So there are a lot of factors here, but maybe we need to see it more. The results.
Yeah.
We can
You're right.
discuss
So
those later, those cases
yeah,
later
But
in.
sure.
the, the
We are observing and keeping the patients after the suture removal. We will again see for after the suture removal the vision also. So the
But I
final.
will ask you a different question. I will ask you a different question. If it's your eyes and you had Bicky B, you'll see 6.6, and you had Dulk, you'll 6.75, one line less. Which one you choose for your eyes?
The DALC is always superior, sir.
Okay, so that's the long-term safety, and it's even if one line less, it's still the safety is the far priority. And I think we nearly finished now. And thank you all the speaker and panelists. It really was very talk session. We learned a lot from it. I'm sure all the participants learned something from it, and that's very good. And sorry we're out of time, but it's a pleasure to have you all with us. And this is a very nice discussion and very extremely nice presentation by all of you.
Dr. Osama, if you
Dr.
allow me,
Mohammed?
thank you all for this speaker and panelists. It was really great to have you all in the first webinar after the MEOM conference. Now we will go, if you allow me, only within 2 minutes, we will select the winner of this webinars, who is going to win the registration and accommodation for the next MEO from those the attendees. If you are ready, Abdullah, we can do that. So I ask all the attendees to wait. Anyone who is not available now, we will remove him. So I will ask all the attendees, please stay there till we finish that one. Okay. So all of you can see this is by the name. So you can go ahead, Abdullah. Press. Okay, so is the Edgar is here? Can we check if he is here or not? We can go to the chat, please. I'm sorry, the participant, if his name still available, so we'll use. So, and we need him also if he can connect. He can raise the hand. Edgar is the winner of this webinar.
So he has commented hello.
5 seconds to raise his hand.
Sorry?
He is here.
Okay.
No, but he needs to raise his hand. Maybe he's opened the computer at
Yeah, can
for
you raise
sleep,
the
maybe.
hand? I need to raise the hand. I will open and
He
I
did.
need.
He did.
Huh?
He raised the hand.
Okay, great.
Okay.
So congratulations for the Edgar for being selected this webinar, and he went to be registered and accommodation for the next meeting. If your email there, so they will contact you after a while and they will finalize this with you for the next year. Before we move, we want just to show you one movie. Then we will close. It will be about 2 minutes. We need also our attendees to wait and see it. Abdullah. This is a promo of the last conference. Not working. Abdullah is not working. I think. Okay, so if it's not working, so it will be for the next meeting because we are too late. And I think everybody, especially in India, Bangladesh, they are 1.5 hours before us. Thank you. Really, I want to thank Dr. Mohsen, Dr. Abarna, Dr. Cosimo, Artasha, Dr. Osama, Dr. Krishna, all the experts. And also, I would like to thank all our speakers, Karan, Dr. Ashraful, I couldn't remember the others. Sorry, I have to read the names easily. Ramazanova, and also we need to ask Rabia. Thanks all of them. And we hope to see you, inshallah, for the next meeting. It will be on 13th of December, another webinar. Thank you and good night. See you. Thanks a lot. Bye-bye.
Thank you very much. That's a pleasure.
Bye-bye. Anyone here, anyone
I'm Dr. Shangila Azhar. It's a great pleasure to be here with you also.
Yeah, MEOM, I feel it's more open.
The city has its own vibe and energy, and also I think this is reflected in MEOM meeting also. It's very energetic and I like it.
The MEOM meeting is getting more and more popular, and it is getting more and more professional.
Thank you very much for all of you, and see you inshallah in another webinars, and see you also in the next MEOM meeting in 2026. Dr. Tashaz, thank you very much for being with us in MEOM and also in being with us today here.
Thank you. We are going to meet you next year, my friend. Thank you.
Thank you very much. All of you, good night. Thank you, Usama. Assalamu alaikum. Bye-bye.
Thank you.